Hello, everyone, to today's Epidemic Ethics virtual seminar on long COVID, minding the gap between infectious disease and chronic condition. So we're focusing on long COVID today, which is sometimes referred to as a syndrome or a collection of symptoms that persist or emerge in people who have recovered from COVID-19 several weeks after the initial infection. I know there are many gaps in terms of what we know about long COVID, but we do know that it is real. It afflicts many people. It affects their quality of life, their family relationships, and work life. And it raises many ethical issues, such as how we set research priorities in response to this uh, emerging pandemic, how we care for long COVID patients, what obligations we have to prevent or mitigate infections given the prospect of long COVID, and how we tackle these challenges in the context of an unsettled definition and diagnostic criteria for long COVID. So hello everyone, my name is Teck Chuan. I'm assistant professor at the Center for Biomedical Ethics at the Yong Loo Lin School of Medicine at the National University of Singapore. Today I'm joined by three expert panelists, Dr. Rachel Grob, Dr. Ifania Ensofo, and Dr. Janet Diaz. Before I introduce them a little bit further, let me just tell everyone how the session will run today, right? So each panelist will give about 5 minutes of introductory remarks on the topic, and then we go into panel discussion and Q&A, where we will address the key questions for the seminar, as well as questions or comments that have been submitted by you at the registration point, as well as during the live discussion itself. So I'll be looking at the Q&A function for your questions. So can I remind everyone, invite everyone to use the Q&A function to direct questions to our three panelists, and to use the chat function just to say hello to everyone. Okay, and so if you see questions on the Q&A that you like or regard as important, please click like on this question so that these questions will be prioritized for asking to the panelists. Okay, so I should also let you know that the seminar is being recorded and it will be available on the Epidemic Ethics website later in the week. It's also being live streamed to the Global Health Network's Facebook page at this very moment, and the recording will be available there too. So I'm just going to invite our very first speaker, Dr. Janet Diaz, who's the lead who's the lead of the clinical management of COVID-19 at the WHO World Health Emergencies Program. And that unit is responsible for readiness and response to emerging infectious disease. It's also responsible for advancing the clinical research agenda around this infectious disease, including developing the COVID-19 living guidelines on therapeutics and clinical management. So over to you, Janet.
Thank you, and good afternoon, good morning, good evening, colleagues. It's a pleasure to be here. And I was just going to give some opening remarks. Looking forward to a very vibrant discussion with the colleagues on the call. I kind of want to just put out some numbers. I think some of the more interesting numbers that have been published, and although it's not been in peer review, it is in preprint from IHME group, that what is the burden of post-COVID-19 condition or long COVID. And in their estimates, they estimated about and this is estimates up to the end of 2021, so not to current, but it's 2021, about 4 billion people had been infected with SARS-CoV-2. And of those, the estimate was about 3.7% had developed post-COVID-19 condition. And they used our case definition for that, for these estimates. So that, using that proportion of nearly 4 billion, it leaves you with about 144 million people affected. So this is the most recent estimates of burden of disease. And again, this is until the end of 2021. They looked at 3 symptom clusters: fatigue, cognitive dysfunction, cognitive problems, and shortness of breath. They did find that females and those with more severe COVID-19 had more episodes of post-COVID-19 condition. But I do wanted to acknowledge, though it doesn't mean, but however, the absolute numbers of patients who get post-COVID-19 is really higher in those that are non-severe, not hospitalized, those with community infections, because of the sheer numbers of those patients. The median duration of symptoms in their estimates was about 4 months in community infections, and up to 9 months in those that were hospitalized. And they estimated about 15% of patients had persistent symptoms at 12 months. So again, a prolonged course for some patients. So when we go back, and so this was, I think, published maybe about a month ago, and They were kind enough to present these data at one of the webinars we hosted. But if you go back from the beginning of the pandemic, what really brought all this attention to us was patients, were people who were living with post-COVID-19 condition, those people earlier in the pandemic after the first big waves, noting that they had persistent symptoms at that time. And they really came to us, came directly to WHO, came to the DG, asking for three things: recognition, research, and rehabilitation. And those asks were relatively clear, and I think continue to this day. And I kind of want to say those three strategic pillars are really withstand the time, and they're still the things that we need to continue to work on. Although much work has been done, much work still needs to be done. In regards to recognition, that was really raising the awareness of people, communities, public health officials, clinicians, doctors, nurses, all the specialists working in healthcare about this as a real condition, and because the case definition, which we did publish at the end of October, in October 2021, but because it was hard to understand, the clinical syndrome, the phenotypes, there was a delay, I think, in getting a good case definition out there, and many different groups then published different case definitions. But really trying to put together a case definition, which WHO did publish for adults. And actually, we just recently adapted it for children, but that has not yet been published. So hopefully in the next month or so will be published. But the importance of having a standardized case definition, clinical case definition that people can use to try to diagnose patients, to get them into the appropriate care pathways, and to also include in research. Right? Because again, you want to also study interventions, and I'm going to talk about that a little bit more in a second. So the recognition was key. The second was research. And I think at the beginning, it was understanding the clinical presentations, standardized data collection forms. So WHO did publish a common clinical case record form. So try to kind of provide some standards of collecting symptoms, tests, in order to describe what long COVID was. And that we saw not a lot, but we started to see studies, mostly from high-income countries. And I think this is where a research gap continues to exist. What was the understanding in high-income countries, but what were we seeing in other parts of the world, in other resource-limited settings? What were we seeing around there? And those publications have emerged, but much slower and smaller than what we've seen out of some other countries. So there is a gap there. In addition to understanding the clinical phenotype, then it was like, what interventions, right? So and the two big interventions one we're thinking is like, are there pharmaceutical interventions? Is there a treatment? But because our understanding on the pathophysiology was also limited, everything was going on simultaneously trying to understand the pathophysiology. Is it immune mediated? Is it thrombotic related? And I'm not going to talk about the potential hypothesis, and our understanding has increased, but then started to use targeted treatments and testing them in trials. And I think that's where we've had a big delay as well. We recently did a systematic review to look at what's been published on treatments for post-COVID-19 condition, and resulted studies are very few still, very, very few. Although there's many in process, still very few. So we were not able to get up, the big platform trials like we did for acute COVID, for post-COVID-19 condition, like we should have, I think. And then finally, rehabilitation. Rehabilitation, and I think it's the care pathway. And just to acknowledge what was said before, the clinical guidelines that we write, the first time we had a recommendation for post-COVID-19 condition was back in May of 2020. So, and in that we had one simple recommendation, which I do think was key and probably hasn't changed, that it was important to set up national coordinated clinical care pathways for patients, and to make sure patients were followed to recovery. And so just that idea that, like, just because you're done with your acute COVID, that you don't need any more care, we were trying to get that early, that patients should be followed to full recovery. And if they didn't fully recover, then get cared for in a coordinated, integrated, multidisciplinary manner. Now, a lot of work is going into care models right now, different care models in different countries, distinct clinics that do post-COVID, or primary care-based clinics that then refer out to specialists. So we don't have the answer yet as the best model for care, but we do know it's important to have a holistic approach, a multidisciplinary approach, and that rehab interventions are some of the key interventions for symptom management. And we were able to update our guideline just last month, to include rehab interventions now for post-COVID-19 condition in that last updated guideline. So just to summarize, so just to end off there, the recognition, research, and rehabilitation remain important. We have made some progress in all of it, but not enough. And then the burden of disease is high. If we look at these estimates, and hopefully we'll see more estimates of the years of 2022. But it's here. Patients have this. The health systems have to be ready. Clinicians, caregivers need to be ready, and then also the impact and the disability, or the impact on patients' lives, their ability to work. This all needs to be taken into account in a broader context, not just health. So with that, I hand over, and thanks for the opportunity.
Thanks, Janet. I think what you said just have addressed a question from a participant on whether there are any existing studies on understanding long COVID. We're gonna invite now Rachel Grob to speak, and I think she'll be showing us a video, and I think her talk will be looking at the intersection between recognition and research.
Wonderful. Good morning, everybody. Okay, hopefully you can see this, yes? Okay, so yeah, I'm going to speak to you about an aspect that Dr. Diaz already referred to of long COVID, which is that patients really identified, addressed, and also began to research long COVID from the start. And you can see a variety of publications that were produced, for example, by the Patient-Led Research Collaborative, and also a tremendous sort of crowdsourcing and web-based social media effort for people to connect to each other around this novel aspect of COVID in real time. So from the beginning, these patient experiences have sort of pushed long COVID in, I think, some very useful and provocative ways. Hopefully we can take up some of those questions in the Q&A. But today I want to share with you directly some video of people talking about those experiences that were collected under the umbrella of DIPEX International, which plays a specific role with respect to lived experiences, using a rigorous qualitative methodology for analyzing health experiences. We video and audio tape those interviews, and we publish them on the web as well as in the peer-reviewed literature. So we began looking at COVID as an international collaborative in the summer of 2020. We've got a Social Science and Medicine Qualitative Health Research special issue forthcoming that'll summarize a lot of those data. But in line with our sort of special role with respect to patients' voices, we focus on marrying the rigor of scientific investigations of health experiences with the depth and dimension embodied in narrative data, something we've written about a few times. You can see that in these slides. So today I'm going to share with you a montage from 8 countries who focused in on long COVID experiences. We did a rapid cross-national comparison to derive relevant themes from 167 interviews collected from Australia, Spain, Brazil, the UK, Canada, the US, Japan, and the Netherlands. So not nearly as representative of global experiences as we would like, but at least sort of a starting place that we thought would be useful and provocative to share with you today. These are the themes that you're going to hear. Most of them, due to the shortness of time, we're not going to focus in on the better public messaging, but we can take that up at the end. But here are some of the things that really stood out in our analysis of these 167 interviews around these 8 countries. The diversity and disruption characteristic of symptoms, how hard the social impact is and how difficult it is to get benefits and help with those, the way health systems are continuing to kind of struggle and adapt in terms of managing referrals, as well as Dr. Diaz referred to, the sort of emerging clinical interventions, how there are few treatments, but how important it is to patients to just be sort of heard, believed, and listened to. And then we heard some people saying that they don't show up at all to seek care because they don't think much can be done. And that can be a valuable way that this kind of research can illuminate what's going on that we wouldn't see from clinical research. So here we go. Have a listen. I'm going to cut this off at about 5 minutes and then just wrap up really quickly.
Ik kan gewoon niet meer de dingen die ik kon. En dat maakt gewoon het probleem. Voordat ik ziek werd, gingen we autovakanties, ver weg autorijden. Maar alles wat je doet is beperkt. Ook natuurlijk, mijn vrouw heeft er ook onder te lijden. Want je kunt niet meer die dingen samen doen wat je eigenlijk al die tijd gedaan hebt. De kinderen, idem dito, stoeien, dat soort zaken. Kan het niet met mijn spieren en ik heb gewoon de krachten niet meer voor.
Comecei a sentir uma dificuldade absurda, né? Assim, de não ter interesse para ver um filme, para nada, assim. Eu falei, cara, não consigo focar, não consigo prestar atenção em algumas coisas. Ler jornal, eu sinto essa dificuldade de foco, né? De você se concentrar numa coisa, eu ficar meio que disperso e de esquecer as coisas, de eu combinar. E aí eu comecei a usar post-it de coisas que eu não precisava, assim, não me sentia numa necessidade de fazer isso.
もうお金がないんですよ。もう本当にもう退院してからのかかる医療費って結構かかりますから。まあね、本当に後遺症に関しては何とかしてほしいですが、何が後遺症で何かこれは違うとか、分けることもできませんし、まあできればね、保証してほしいですけどね、そういったのは今は期待できないかなと。家庭の時ですから自助でやってくださいって言われますからね、ここの政府は。
Y en esas estoy, en ese momento estoy trabajando con depresión. Pero claro, es que si esto no tiene fin, ¿qué hacemos? Que dentro de nada ya te dirán, pues tienes que ir a, ¿sabes? Y eso es una angustia, porque claro, es que si no puedes un trabajo.
The entire process of PIP has been so dehumanizing and horrible, to the point where I feel like over and over again I have to prove and articulate and specify specifically how my illness, my disability makes my life worse and makes it difficult, and open my entire life and existence wide open for them to say no, to specifically denigrate and to give frankly insulting means of rebuttal of me, just grinding. It's dehumanizing. It's a sense of not trying to find out your needs and your disability, but as if it's like a lie detector test.
The GP perspective, I absolutely get the fact that I am not dying, and that there are more people with more serious conditions than me that the medical profession needs to give its time to. But my life has been completely turned upside down, and the lack of support has been galling.
Unfortunately, there was no drugs or anything that she could give me. But she said, take Tylenol, rest when you can, try not to take on too much when you're feeling unwell. And those were really the words of advice that she gave. She just kept saying, there's not enough research, there's not enough information right now as to what long COVID is or how to treat it, or, you know, so that was really the conversation. Even with the infectious disease specialist, it was the same thing.
Like I had hot lungs, I had sticky lungs. I appreciate that Dr. D uses my lung terminology when he's talking with me to like ask him questions, or he's like, you know, like understand the quality. And I do feel like there's a transactional component to the learning. You know, he shares what he does know. He stays up on the science and the literature that comes out. That's clear to me in our appointments. He's also, though, like, I think like he really does approach it as that partnership, and also like he, you know, I am someone that he is learning from. You know what I mean?
So recently, 3 days ago, lost the feeling in my hand for some time. My hands went suddenly blue. I have no confidence, to be honest, to contacting any doctor in regards to that, because it didn't help me in the past. So I'm not contacting anyone. I don't know. It's all my tests were fine. So whatever happens to me, there is no not good answer, I guess, at this stage.
You had COVID and it was like a cold, like, what the hell are you complaining about? You know, so many people died from COVID and are dying from COVID. I think it contributes to my hesitancy or my hesitation, but I think my primary hesitation is like thinking it's a waste of everyone's time. So I think it's more just like feeling like there's not much that's known or can be done.
Okay, just a reminder that through DIPEX International, many of us publish these studies online. So there's a live site already in the UK and in Japan. And I just want to acknowledge some funding to get this work going, and all the people in DIPEX International who did these interviews and folks who helped with the presentation.
Thanks, Rachel. So Rachel's the chair of the DIPEX International. She's also the scientist who directs the qualitative and health experiences research lab at the University of Wisconsin-Madison. So those patients really report a wide range of symptoms and conditions, and what I perceive is that, you know, the struggle with trying to explain long COVID to other people. So I think that might be one of the toughest challenges for sufferers. I think there are many questions being raised here, but I'll just jump to Ifeanyi and so forth. Let me just introduce himself. Dr. Ifeanyi, who's a public health physician with many, many years of experience, 23 years to be exact. He's a Senior Atlantic Fellow for Health Equity at George Washington University and an Innovation Fellow at Pandemic Tech. He's been interviewed by many outlets, news outlets such as New York Times, BBC, etc., Lancet, and he has authored more than 105 opinion pieces, 50 of which are COVID-19, including long COVID. Over to you, Ifeanyi.
All right, thank you so much, Tech. You know, and it's really good to hear from the other two panelists. So just taking off from Rachel's presentation, when I looked at that map where the research was done, I think that pretty much, you know, tells you what's happening in Africa. Because, you know, people are not looking from outside into the continent to find out what is happening. And I also think within the continent, we are not also asking questions, measuring, and, you know, so that we can find out, you know, the burden and the kind of care that our people need. So for me, as a public health physician, it's usually, you know, I'm more focused on prevention, being better than cure. And I also need to acknowledge that today is World Mental Health Day, which is quite significant because, you know, some of the symptoms of long COVID, you know, border on mental health. And as I go further, you realize why for me that's very important, especially in Nigeria, where mental health perception services are really, really very poor. I've always advocated for, you know, COVID-19, including vaccination. And last year, once the vaccines came on board, part of my advocacy also included long COVID, because I thought that people needed to know that one of the consequences of COVID-19 is long COVID, so that they can make an informed decision. It wasn't my way of scaring people, but I think people need to have the right information so that they know the right decision to make as far as prevention of COVID is concerned, but most importantly, as far as COVID-19 vaccination is concerned. And for me, when it comes to long COVID in Nigeria and indeed other parts of Africa, I was shocked. Early this year, I was a consultant to BBC Media Action, and when I was training radio journalists from 12 states in Nigeria, Nigeria has 37 states. And when I got to the point about long COVID, none of these journalists from those 12 states in Nigeria had heard of long COVID. And for me, that was quite worrisome, because these were the people who were informing the public about COVID-19, about COVID-19 vaccination, and why they needed to get vaccinated. And if this crop of people did not know, hadn't heard of long COVID before that particular training, then I knew we were in trouble. And of course, there were all sorts of resources I had also looked at as part of my advocacy campaign. The one that really appealed to me, similar to the work Rachel and colleagues have done, is the Voices of Long COVID, that was curated by Resolve to Save Lives. Individuals sharing their experiences about long COVID and how these different symptoms had really affected their lives. And of course, in my work, I've also talked to different clinicians in Nigeria, and people just keep telling me there's no long COVID in Nigeria. But I think that's not the true picture, because you cannot say there's no long COVID when you've not asked questions, when you're not measuring, when you're not in contact with people who have recovered from COVID-19 and are dealing with all sorts of symptoms afterwards. So we're not measuring as much as we should measure here in Nigeria. And for me, on a personal level, a colleague, she has been dealing with one of the long COVID symptoms, lack of smell for the past 1 year. It really upends her life, because, even to cook, to eat, to interact with her family is difficult for her. And yet, clinicians are telling me there's no long COVID in Nigeria. I think it's not the true picture. And coincidentally, recently, the acting director of the Africa Center for Disease Control, Dr. Ahmed Ogwell Uma, was interviewed by the Lancet. And this was what he said. He said, unfortunately, many people with long COVID do not return to health facilities, but instead try to manage it from home, which makes it very difficult for us to have a clear picture of the incidence of long COVID across Africa. Why what he has said is true, but I think it's also not the complete picture, because people would only begin to report if they knew about it. And really, from my work and from my writing, from my speaking engagement, as well as from the research I've done on a personal level, this is not, people don't talk about long COVID on the continent. So if people are not even aware that long COVID exists and what some of the symptoms are, then how can they come back to health facilities to tell you about long COVID when they begin to feel the symptoms? They would just assume that, well, this is probably something else that we're dealing with. This is something not related to COVID-19 at all. And Dr. Uma went ahead to say that the Africa CDC will work towards better tracking of patients with long COVID across Africa to ensure that the required medical care is provided. I hope that happens, because for me, it is really very worrisome that we are not, we're not asking the questions and we're not measuring. And I like, where Janet started about recognition, research, and rehabilitation. These three really are not happening on the continent. And let me tell you why the mental health consequences of long COVID are very important for a country like Nigeria. In 2019, I was a co-lead of the Mental Health in Nigeria survey, where we interviewed more than 5,000 people across the country to gauge their perception about mental health issues. And 70% of our respondents said that, when we asked them, what do you understand by mental health disease? And they said that it is when someone starts running around naked. 70% of Nigerians. So with this kind of perception, you can imagine someone who has like brain fog as a result of long COVID. The shame and the stigma of that will not even allow the person to share with friends and colleagues. not to talk of, going to health center, to seek care. And that's why for me, what I think is very important is that we need to really begin to educate people. Health education, as far as long COVID is concerned, I think is the first place to start. We need to educate, our communities. We need to educate health workers. We need to educate, our legislators, policymakers, so that they will begin to now realize that this is a huge issue globally as well as in Africa. And I think that, to end, I think the University of Global Health Equity in Rwanda really captures the essence of health education, because they say that achieving equity in healthcare depends on equity in health education. And for me, what that really means is that for people to make the right decision, whether they are health workers, policymakers, legislators, name it, researchers, they need to know first, because that is what is going to pique their interest to begin to say, okay, how do we, recognize that this long COVID is a big issue? How do we conduct the best research? And of course, how do we, provide the rehabilitation that people need? And Jenna, this is me riding on what you said. So, yeah. So I hope to end here, and so that we can discuss what questions and comments may come. Thank you.
Thank you, Ifani. I'm just going to put you on the spot first and ask you the very first question.
Yeah.
So you mentioned that we have a duty to inform people about what sort of measures they ought to follow in order to sort of prevent themselves from being infected, right? There has to be obligations to provide care and so forth, to recognize it as disease and so forth. What ethical obligations do you think we have, society as a whole, government, to prevent and mitigate SARS-CoV-2 infections, given that we want to prevent COVID, long COVID?
Okay, so again, I think most importantly, we need to educate our people, whether it's at different levels. Health workers need to up their information, their knowledge about COVID-19 and all the consequences of COVID-19. Every day people need to know how COVID is transmitted, how to prevent it, and indeed also the importance of vaccination, so that people get vaccinated. And for me, once people know the right things, that is really the first step for you to begin to ask the right questions and seek the care, that you need. And education also helps, health education also helps reduce the stigma that people face, especially with mental health in this part of the country, in this part of the world. And I think that another ethical thing to do is the global health community need to also prioritize Africa. This is a continent of 1.2 billion people. We know what the prevalence rate of long COVID is based on Janet's presentation. So we can estimate the burden of long COVID on the continent. So the ethical thing to do would be that, the next phase of this research that unpacks, voices of people with long COVID should include sufferers from the continent too. Because, we know at least from all the systematic reviews and evidence that generated that this is a big issue. And I like the way that the Lancet put it, this is the next pandemic that we're dealing with. So for me, those ethical issues at, health education level, but also at global health level, prioritizing long COVID in Africa, I think it's, those are things we need to really highlight. Thank you.
Janet and Richard, would you have any comments?
Yeah, I mean, I agree entirely, and I'm hoping maybe we can connect afterwards, or if there are other people here from the point of view of global health experiences research. We are always looking for teams and countries who want to do this work, and we don't, we try to reach out, but we are here hoping to do that. I saw another question about what are the low and middle income countries that are just under the DIPEX International umbrella, and Brazil is really the first one who's joined this collaborative. We have colleagues in Kenya who've been working not so much on long COVID, but on other health experiences issues. But please get in touch with me, Rachel Grab, University of Wisconsin-Madison. I would love to work together to bring those voices to the fore and create whatever partnerships we can.
Janet?
Just to complement that, I think because of I do it again to acknowledge really the work, the initial work on advocacy that was done by patient groups, as Rachel described in her initial slides on the patient-led research and community-led research, and also even the naming, and I'm just going to phrase that again, also it's like the naming of long COVID, right? And how that came about, and we WHO, the naming department here has named it post-COVID-19 condition, but that's not to discredit actually the long COVID name that's being, that's commonly used in the public. And I do wonder, those experiencing long COVID in Africa and different parts of the world where maybe under-recognized, and under-described, is it the same, or are people using different descriptors? And it would be nice, again, like Rachel showed, that the patient interviews to kind of start to hear in patients' own words, what is it that they're experiencing? So when the clinician has to ask the question, I'm a medical doctor, you need to ask questions in a way that, not in sometimes it's not in that cognitive dysfunction, right? That maybe that doesn't really make any sense to some patients, whereas brain fog or whatever, trouble concentrating. So I do wonder how we can improve the communication about this, the explanations around, because we do have case definition, but maybe it's not making it everywhere, or maybe it's not easily understood in all different parts of the different areas. And then just to acknowledge the WHO clinical data platform, and I did put our link to our website that has just been updated to try to keep kind of live a little bit our webinar series, our clinical data platform, which supports and could support Nigeria and other countries in standardized data collection, so that then you can describe patients in your own, country, at the national or subnational level, and see what are the common symptoms experienced, and that could probably be complemented with these patient type interviews, so you have some qualitative work and then some, analytic work. So I think there is opportunities, but it is a focus. I think we have to take more focus and a strategic approach and actions through working together to accelerate an understanding in different parts of the world.
Yeah, I have a question for Rachel. I guess, are you observing any differences? I think there's something that's raised by Janet herself. Are you observing any differences between how healthcare professionals and patients characterize long COVID? And are there any differences between patients from different settings, say between high income and low income settings?
Yeah, it's a really good question. I think one of the reasons actually that long COVID was named and identified so early and sort of effectively is that, of course, healthcare workers suffered very high rates of acute COVID infection because they were essential workers, and they therefore were some of the first people to have long COVID in large numbers and were able to sort of use their scientific training together with their lived experiences to be very effective advocates and to pull together or participate in, along with other folks, pulling together some of these patient-led research collaboratives and be able to publish in places like the Lancet. We have not done an explicit analysis ourselves of the language question, but I think the point is very well made that the way people talk about things, the words that they use, matter a lot. We would love to do those sorts of analyses because that kind of phenomenological expression has in other instances really helped not only with connection and some of the kinds of issues around stigma that Ifeanyi was referring to, which we hear a lot in patient stories, but also in guiding diagnostics and directions for research. There's been some interesting work done on epilepsy, for example, in the past, where the specific descriptions of seizure activity led to a refinement in our understanding of what's actually going on sort of neurologically in the brain. So I think that that can be true here, and that what we need for this kind of thing is a sort of teaming up and a continued breaking down of the barriers between how people think about the value of qualitative research and how they think about the way clinical trials and other sorts of evidence production are organized. And I think those conversations are really productive in the long COVID space because it is so prevalent, as Janet pointed out, and because it is so sort of understood and made public, as Afanya pointed out, for the continent and in other places around the globe.
If I need to have a follow-up comment.
Yes, I do. So to me, I totally agree with the nomenclature. How do you describe the symptoms? But I think if we start, let's go back to the first principle here, because when lots of clinicians and other advocates do not know about long COVID or do not think that long COVID is a problem, then they will not even, they don't want to know how to ask these questions. Because I think once we deal with that level of lack of knowledge, maybe through continuous professional development or through WHO, for instance, putting out some key outputs there as far as long COVID is concerned, then at least the healthcare providers can even be proactive to say, okay, because we know that long COVID is likely, if you're somebody that has recovered from COVID and we treated you, we can at least be proactive and ask you the question, are you feeling some of these symptoms? Then you can now say, okay, actually I am, and this is for how long? And that helps the person, recall and indeed prioritize it. Because another challenge that we have in this part of the world is very poor health seeking behaviors. When people are sick, they don't go to health facilities most of the time. They go to community pharmacies. And most of the time, the community pharmacies are not run by professionals. The person just treats you for the, for the body ache, treats you for whatever it is that you treat, and the treatment is in quotes. So I think we need to also begin to find ways of ensuring that healthcare providers know about long COVID, would prioritize it and know that it's important, so that can now help them to ask the right questions. And on the other hand, like I said when I was speaking initially, the BBC Media Action Consultancy that I did, training radio journalists, I think journalists are very, very, very key here, because they are the ones that really educate the public much more than we do. So we need to see them also begin to know about long COVID, what the symptoms, the right way to ask the questions, so that when community members have this information and they go to their healthcare provider, they can at least preempt and say, well, this is what we heard, and indeed, I've been having these symptoms. What do you think? Because I think when we do all that, we put power in the hands of, long COVID sufferers, but also educate the healthcare providers so that, we provide care. When you watch these videos, these personal videos, like was shown, and even the long COVID stories from Resolve to Save Lives, you see the amount of suffering people are going through. So imagine, the number of people going through that across Africa, and nobody, we're not hearing their voices. And I think we need to do everything possible to make sure that their voices are also heard. Thank you.
It's a quick question. I guess you can answer very quickly. Whether there's any form of community engagement happening in your context on long COVID.
To be honest, not to my knowledge, because when I speak about long COVID or COVID, they need to get vaccinated generally, I seem to be the lone voice as far as long COVID is concerned. I mean, there's a project, that we just ended, a coalition of different organizations supported by the Gates Foundation to use Facebook and Instagram to increase COVID-19 vaccination among healthcare providers in Nigeria. Even in creating the content for that, I was the only person talking about long COVID as a reason that people need to know so that they get vaccinated. So to be honest, I stand to be corrected. It may be happening in some countries, but even then, if some of these researches or inquiries are happening, they need to tell their stories. If they can't publish in peer-reviewed journals, you need to write, or at least share it on social media so that we know. And hopefully, with the kind of partnership that Rachel is talking about, some of these people can be part of the research that her team is doing. Thank you.
Thank you. I have a question for either Janet and Rachel, and it's on patient care. It's an interesting question raised by one of our participants. And the question is whether you think we might be headed to a situation where symptoms classified as long COVID will be in danger of being exploited for the purpose of obtaining disability benefit. Has a standardized criteria been developed to demarcate those in need of disability benefit versus those that do not? So again, this raises many issues and principles such as respect for people, non-maleficence, and things like that. So over to you both.
I'm trying to figure out, Janet, if you want to go first or second. Do you want to speak first? Go ahead. I would say that by and large, people want to be well. They do not want to be sick. And they are struggling very hard, and you heard this in the videos, to sort of survive this tsunami of misery. I do not think that people are taking advantage of over generous welfare states in order to sort of give themselves a break. I think rather, at least what we are hearing in our research, is people who are being very heroic in their daily lives, trying to manage illness and work and children and family experience, and kind of bumping up against systems that, even if they are generally attuned to need in a compassionate way, which is not true around the globe, but even were it to be true in countries where the social welfare net is stronger and there's wealth, like in some of the European countries, those systems have not yet adapted to the reality of long COVID, and they don't know the right questions to ask, or they don't have the right time frame. So I think that the obverse is what is being experienced on the ground now, at least according to our research.
I'll just add, and I agree with Rachel on this, about people wanting to get better, people wanting to not have a symptom that keeps them unable to do what they like to do, be it work or be it at other activities, but whatever it is that they functionally were doing prior to getting sick and not getting back to that previous state of health. So I do believe that, and I also think there's limited, much more work needs to be done now that now that we're starting to get an estimate of numbers that may be somewhere closer to truth, and the burden that has, and then you have to kind of see about and the IHME report tries to do that, like what is the quality of life, right? Where are the impacts of the symptom or symptoms impacting a person's ability to go back to work, to do these activities? And then how does that, how are we quantifying that? And I don't think we have good understanding of that, and that would imply, some people potentially not being able to resume work as they were before, or different types of work. But I think, and what we need to try to put into place, which I think is, care systems and care interventions to try to get people back, to the way we were before, and be it rehabilitation, occupational therapy, physical therapy, mental health interventions, a multi-pronged approach based on the patient's needs, in order to build back health and functionality, where they may have, where the symptoms may have, caused limitations. So I think there's, you know, a lot more to understand on that still. So
Yeah, so there's really a lot more we can understand, a lot more we can do research on, you know, how we treat, how we prevent patient experiences and so forth. You know, so question for Janet, you know, how should we set research priorities for long COVID, both in terms of other COVID related kind of research and research more generally? And as one of our participants asked, you know, how can we ensure that when we prioritize research for, say, long COVID, we don't relegate other important ongoing research?
So I think it has to be a really inclusive process with all important stakeholders, you know, and WHR does some of this, you know, through the R&D platform for research in COVID. The last big meeting, I think, I can't remember now, a few months ago, did have a small session on post-COVID-19 condition. So I do think right now for this COVID-19, but also for other emerging infectious diseases, we are really needing to emphasize this post-acute illness, and I'm not going to, one could say post-viral, but maybe it's not always the virus, but the post-acute illness, acute infectious period, recovery time, and if they don't recover, what is, you know, what kind of illness do people maybe have for, you know, for perhaps a subacute or chronic time. So I think there's this topic in itself is something that I think we have to integrate better into our pandemic preparedness, readiness, and response. You know, this time period of a patient after the acute infection, what is happening? Did patients recover to back normal health? Did they not? And what is this condition? And how are we caring for patients during that time period, which is really key. And setting the research agenda around that means that you have to include this early on in the research agenda. And maybe we didn't do that early on for post-COVID-19 condition, in the sense that we did a lot of emphasis on the acute illness, treatments, vaccines, but maybe didn't say at the beginning, also some aspect of work needs to be put into place right away. And there were some groups that did do this. And then patients themselves who did do this were started to do the observational studies. So I do think we need to remember this for the future, and now just be as inclusive as possible with all various stakeholders in order to advance and listen to your population, you know, and listen to the needs of the communities in order to prioritize research, and also to the donors. I think funding, I'm not, you know, I know we're not talking about funding, but funding has to be made available in order to conduct these studies and to conduct, even if models, you know, let's say models of care interventions, if someone wants to evaluate those. So finances and money for research needs to be made available.
If any, would you want to jump in? Should we prioritize on prevention?
Yeah, I mean, we should prioritize on prevention, but, you know, so many people have recovered from COVID and are suffering from long COVID. So we need to also really prioritize that. And I think, you know, just taking off from where Janet, one of the comments she made about funding, I think probably a way to look at this is every COVID-19 funding now should come with, you know, funding for long COVID. Yeah, because I mean, even if you're supporting vaccination, you know, or supporting prevention activities, you know, a component of that funding should be dedicated to long COVID, whether it's research, whether it's training of health workers on long COVID, whether it's community education on long COVID, because we know that this is an existential threat. We can't run away from it. It's here, you know. So I think it's probably easier to convince a donor who is already funding COVID to say, okay, this is what we're dealing with. Can we set aside a certain proportion of that funding, you know, to deal with long COVID, you know? But funding is really key, because I think that would really unravel, you know, so many challenges that we are having in Africa, for instance, as far as long COVID is concerned. Thank you.
Question for Rachel. So, you know, given that you have done so much of the patient experience kind of research, do you see that this patient experience would actually be incorporated in the definition and characterization of long COVID? And do you see any challenges with that? Or will it be health professionals that will be dominating the how it is characterized and defined?
Yeah, but I think, as Janet pointed out, that patients' experiences have already been catalytic in naming the condition and in helping people in the research world kind of get hold of what is going on already and what we should continue to investigate. So I think the question is going to be, how does that relationship continue to unfold? And my hunch, and I'm interested in what Fanny and Janet will think about this, is that long COVID will be have aspects that remain mysterious for quite some time, and that the health experiences data is going to be really key. We have often novel conditions that emerge, but of course, acute COVID was a pandemic of scope that we hadn't really seen at least in a century. And long COVID, as the Lancet article pointed out, is another epidemic. 4.5 million people globally, and we know that that's an underestimate because it doesn't even count 2022 when there's been, high rates of infection, maybe lower yield, but certainly there's some long COVID there. And we continue to have COVID, despite what some people might want to believe. So I think the question is, how can we harness these different sources of evidence most effectively so that both clinical intervention development is well informed, but also, as Ifani has pointed out several times so effectively today, people are not feeling so stigmatized and so invisible and so unseen and so unheard that they don't even show up anywhere. We've heard in our interviews people saying they haven't even told their family and friends about their lasting illness, much less trying to show up even at the community pharmacy or anywhere else. So we really need, I think, a revolution in our public discourse that should be very richly informed by narratives, as well as these partnerships around research. And Janet did say the F word for funding, like we need, I think, well-funded programs of research that take into account the importance of the lived experience side, as well as other kinds of investigations.
Yeah, so I have a conversation with my respiratory specialist a couple of months back, and he was saying that, I can't focus on long COVID patients because I have on my hands full of acute patients, not just long COVID, not just COVID patients and things like that. And secondly, he doesn't know how to sort of treat them in the first place. So, advise them, ask them to manage, give them certain strategies to manage their condition and things like that. How much do you think that our focus on the acute side of things have affected our neglect of the chronic side of things? Open up for all the.
I think maybe I'll just comment. I guess we're going to head to the end of the call soon, I think.
Yep.
I think it's similar to what I had said before. I do think we needed to be a little bit more broad at the beginning, remembering that not all of it stuff is acute. Obviously, the acute stage is bad, and at the beginning of the pandemic, obviously before vaccines and before treatments, effective treatments, there was large amount of people getting severe disease and dying. So there was a lot of loss during those times of human life. So, but we needed to remember from the beginning also that there was going to be patients that we needed to make sure that those that did survive the acute illness got better, got back to full health, had an event, but then they got better. And I think we didn't set up the systems to do that. So potentially clinicians, were working very hard at the time during the peaks of those pandemics, and then not able to have the space in the health system to take care of the patients that, recovered, but didn't fully recover, and still had some important health problems and symptoms that needed to be dealt with. So when I think of those doctors, I also think I was on a call the other day and we were talking about patients needing to be heard, right? And so a 5-minute visit or 10-minute visit with a clinician may not be sufficient time to listen, to be a holistic provider. to try to understand what the patient's experiencing or the patient and their family are experiencing in order then to be able to advise and set up some sort of treatment plan. So I think that is, that's not just a problem, I think, for post-COVID condition or patients with long COVID. It's a problem sometimes for patients with other chronic illnesses that maybe not sufficient time for a visit with a provider. And that's where I think these models of care, are interesting, about who's in the model, who's in the visit, who partakes in the visit with the patient, how much time and interactions are held. And there's, much to learn, I think, from other diseases about care models to see if those apply as well to patients with long COVID. But yes, I think we do have to create space in our health systems to care for patients holistically and to allow time to listen.
To have these conversations. I'm just going to we're running out of time. I'll just give Ifeanyi and Rachel 1 minute each to have their final say before I close the session.
Okay.
Ifeanyi, would you go first?
Okay, thank you. So for me, we may describe, long COVID as chronic, but to the sufferers, every day is acute. Every day is something new, every day probably more severe. So for the healthcare providers, if you're overwhelmed, you have so many patients on your hands, maybe you can refer, to the next level, to another person to see this client. And secondly, I think we also need to acknowledge what some nonprofits are doing in providing care for people with long COVID. And a good example is COVID Aid in the UK. COVID Aid is doing exceptional work, trying to document experiences and also link, sufferers with care and things like that. And for me, as an African, the African Union did exceptional work coordinating COVID-19 response on the continent through the Africa Center for Disease Control. The African Union should also do the same as far as long COVID is concerned, through the Africa CDC. They have to be proactive to ensure that, people who are suffering from long COVID on the continent are not left on their own and without, any care or any assistance whatsoever. Thank you.
Rachel?
Yeah, I think I just want to acknowledge that it has been a very difficult few years for everyone. And so I think the work here is less about blame or pointing fingers and more to highlight that while the suffering from acute COVID has been extraordinary and continues to be extraordinary, and there's still a very high burden of disease, that long COVID is unfortunately sort of a strong competitor for our attention. And I think it's about sort of making more pie, as the analogy can go, right? Like making the resources and bandwidth, expanding that as much as we can, rather than saying acute versus long, because they're both really important.
Yeah, that's a nice way to put it. So that's all the time we have for everyone. I hope you've enjoyed the webinar. Join me in thanking Ifeanyi, Janet, and Rachel for giving and sharing their expertise. Just remind everyone that the recording will be available soon on the Epidemic Ethics website. And please do check the website for future epidemic ethics webinars. And you can also follow us on Twitter and LinkedIn. Thank you, everyone. And that's all. Thank you.